So I'm provided with X-ray chest frontal and lateral projection of a skeletally mature patient. Looking at the lung fields, the right lung is unremarkable. Left lung also appears unremarkable. There is a retrocardiac opacity in the on the left side. Um, but I cannot see any calcifications. I cannot see any air fluid levels. Okay, I'm looking at the rest of the lung. On the lateral, the retrosternal and retrocardiac lucencies are maintained. Mm, there is no hilar prominence. The mediastinal contour is normal. Cardiac shadow is normal. The lung epiphysis, the hilar, the diaphragmatic contours. This subtle straightening, not even straightening of the diaphragm. The diaphragmatic contour is normal. Um, Looking at the soft tissues and bones, um, the clavicles. So I cannot. Um,
All right, very nice. So,
Definitely.
do you have any differentials in? So, summing up your findings, I think you explained a retrocardiac opacity. Am I right?
Yes, it was a
And
retrocapacity
the
on the.
other major finding that you see, any other?
Actually, with the history of TB, I was thinking of any cavities or fibrosis, apical fibrosis. I don't see any of that. I'm looking for.
Okay,
Um,
so in exam, do not really think that
okay.
the history will be a correct one, absolutely correct. So, irrespective of what the history is, I'd like to, again you to come up with the findings. So the first important findings that you picked up is a retrocardiac opacity. Any other thing that is an association that you see, or the retrocardiac opacity, then in that case you will have to come up with a differential list. So go on. What's your differential or a diagnosis or any
With
other
the
finding that you see on this X-ray?
Okay, with the history of retrocardiac opacity, I can think of AV malformation or a sequestration, or any bronchial atresia, but I don't see any halo sign around it.
All right, I'll take up the case from here because then you have to do more. So first of all, as you mentioned, you can see the arrow. Can
Yes.
you see the arrow? Okay, so this is a retrocardiac opacity. It's
Okay.
ill-defined, but in addition to that, there is blunting of the left costophrenic angle. True?
Yes.
This is an important associated finding which you should not miss. And if you look at the chest wall here, it's not clean. There's some thickening here. There's an irregularity or thickening of the pleura. So when you put up these together, anything else that you can now that comes to mind?
Okay.
Okay, one more thing that I need to tell you.
Yes.
You see this subtle line?
Yes.
You know what this is? This should not be here, right? So this is on the lateral view. You can also see here. You see this one. This is something. The major fissure has been displaced. Now, if you see the right lung compared to the left lung, do you see some difference in the total volume of the lung?
Yes. The left
So
lung
the
appears
left
to
lung,
be
yeah.
reduced
So
in volume.
there's a reduced volume of the lung. So now you understand not only a retrocardiac opacity, but actually there are 4 or 5 findings which associate together. Now, you see, I've just pointed them for you and we explained them. All right. So this was actually a case of round atelectasis. And so we put together rounded lesion, loss of volume, pleural thickening. And what comes to mind is atelectasis. And the reason I said volume loss is important because it then favors this particular diagnosis. In round atelectasis, you see there's a displacement of the major fissures. There is thickening of the pleura. There is a curving appearance of the vessels, which are pointing towards this atelectasis. Typically, these cases, they are asymptomatic sometimes, and they can be incidentally discovered on the just radiograph. So again, another case. Now these are more exuberant and more visible. This one on the thoracic spine, you see anaplasty is projected. Another case which shows a subpleural right lower lobe opacity, and there is hyperlucency here adjacent to it. You can see that there is the vessels which are actually giving a comet tail artifact. This is how you see it on a CT scan. Now, not necessarily every opacity in the retrocardiac location is around atelectasis. So you'll have to come up, as I said, with a differential diagnosis. So when you see such kind of opacities, you can mention a mass, you can mention a consolidation, you can mention a fibrous pleural tumor because there was thickening of the pleura as you saw. And this is, I'll take up an opportunity to actually explain this fibrous pleural tumor to you as well, because this can be shown in the exam. So when you see a lateral chest radiograph where there is, or an AP radiograph, where there's a well-defined margin to a lesion, and another margin is ill-defined. This is called a discrepant margin. And a discrepant margin is a lesion which arises from the chest wall. And one of the most important differentials in such cases is a fibrous tumor of the pleura.
I'm provided with the frontal and lateral chest radiograph of a skeletally mature patient. And I can, in the frontal chest X-ray, I can appreciate that the cardiac shadow is shifted toward the left side, and the bronchovascular markings are apparently normal on the right side. The trachea is central. I cannot appreciate the right CP angle. There is increased translucency within the right lung. The left CP angle appears to be normal. The markings in the left lung appear to be normal. I'm visualizing the bones, and the bones appear to be normal. Okay, now I am seeing the lateral radiograph. There is preserved retrosternal and retrocardiac lucency. Tenting of the diaphragm is noted on the left side. Okay. No abnormality is noted within the spine. So, sir, there is a reduced volume within the left lung as compared to right lung, and increased translucency is noted within the right lower zone. But I cannot appreciate any consolidation.
All right. So what I can understand is that you mentioned that there is increased translucency or hyperlucency in the right side, but
yes, sir. Yes.
Okay, that one, when you fix your findings on such thing, then you have to exclude whether there's a technical factor involved or not in this particular X-ray.
Yes, sir, the patient is more rotated toward the right side.
So that's very important. You do not bring it first up. You stick to your main diagnosis, differential and diagnosis on the basis of your preliminary finding, which is left-sided volume loss or something, is it?
Yes, sir.
Okay. So would you like to know something in the history, or you want to do any further investigations? So how would you take this case up in the exam after this, further on? This is a patient where you have found something. Would you leave it up, or you want to do something else, or what is your differential in this case?
Okay. So as there is a technical factor due to which the right lung appears to be more translucent and more in volume as compared to left lung, so we can I can also ask is there any history, as the patient has a history of long cough I cannot ask the history of any fever or weight loss or any chronic infections or allergy, asthma. And we can also retake the x-rays, or if there is any other investigation like HRCT, so we can also tell you the HRCT as well.
Why would you like to do an HRCT in this case? Why not a simple CT scan with contrast?
Yes, sir. Simple
Because
CT
when you
scan
say
with
HRCT, when you say HRCT, that means you want to look at the interstitium. Did you find anything in the interstitium?
No, sir. Interstitium apparently looks to be normal on both sides.
So you should not say HRCT. You should say, I want to do a CT scan. But even for doing a CT scan, you have to come up with a logical reason. There is a volume loss. Okay, let me explain the case further on. In exam, you have to stick to your preliminary findings, and on the basis of that, you have to come up with further. Whatever you say should be based on that. Volume loss because of what? You mean atelectasis. Do not leave this. If you say atelectasis, you have to take it further. Atelectasis because of what? Compressive atelectasis, obstructive atelectasis. So that is something which should take you to our differential list. Okay, so so the main findings in this case are, so you see, you mentioned there is displacement of the mediastinum, but you left it alone. You never took it further. There's a discrete left hilar. You see the left main bronchus is slightly straightened and inferiorly displaced. This is the right main bronchus, which is more straight, but the left main bronchus is not in the right position. The hilum, it seems to be shifted and more straightened. Now, this is a very subtle finding, I agree, but when there is an indirect sign of straightening of the heart border, of volume loss, so there must be some sort of reason why is the left lung in this patient having volume loss. There is either an enterobronchial lesion, or there is a compression, or there is something else, right? The rotation of the cardiac cillet, and there is a loss of concavity to the left heart border. This actually is called a flat-faced sign. You do not see the left heart border like this. That's a flat-faced sign, which is suggestive of a left lower lobe collapse. In the retrocardiac location, there is subtle hyper-radio-opacity, which also points to something ominous. Yeah. Now, this is the same patient 2 years earlier, right? Almost similar type of findings, but if you see the 2 year earlier radiograph, the volume loss is not there. Now, if you compare it with the previous one, there is certain volume loss. This one is another of the same patient. So these findings were overlooked in this case. 5 months later, patient returned with acute dyspnea, and now it is evident that the patient has a left lower lobe collapse. So a CT scan of the same patient, the coronal view, and then the axial view, you can see that the red arrow is pointing to a lesion in the left main bronchus, and this left main bronchus lesion is causing partial obstruction, and there is distal, you see alveolar shadowing. There is volume loss in this case. So you see the findings of atelectasis, air trapping, some mucoid infection, and post-obstructive pneumonia. This is the case of a bronchial carcinoid. So, but not necessarily. The most important thing in exam is to pick up left lower lobe collapse, volume loss, and point it to the examiner that I am suspicious of a lesion in the bronchus, and I would like to do a CT scan. You can give up a list of differential diagnoses on the basis of CT, like squamous cell carcinoma. You can say mucoepidermoid carcinoma, which has sometimes exactly the similar appearance. A hematoma can look like exactly the same, but that is in case of the CT scan. On the basis, unless you pick it on the X-ray, you cannot go any further. So this was the case of bronchial carcinoma. Now, as I mentioned, if you pick it up on the X-ray and you come up to a CT scan and then you are stuck what it is, I shall mention that left lower collapse can be caused by mucoepidermoid carcinoma, like this one case. Another case in the you see this triangular shadow. There is volume loss in the lateral view. There's a displacement of the fissure. This is very important to see. Most of us, we do not do the lateral X-rays in our country back home, and we're not well versed with the lateral views, but this can be sometimes very helpful. Another case of CT scan with an endobronchial lesion causing post-obstructive left lower consolidation. This is also a proven case of mucoepidermoid carcinoma. And you should also take a look at the trachea. In addition to the bronchi, sometimes you see an endotracheal lesions, which can be a malignancy. Sometimes you can see chronic collapses like this one, the bronchiectatic airways. So if you see collapse with bronchiectasis associated with it, that's a case of chronic collapse. And as I said, not necessarily every lesion which is in the bronchus is a case of bronchial carcinoma. Sometimes you can see a lesion which has some fat inside it, and then a lesion which has mixed attenuation and has fat and it's within the bronchus, always consider a case of endobronchial hematoma.
Yes, sir. So I'm provided with a frontal chest radiograph of an elderly lady. I'm able to appreciate that the cardiac size is within normal limits. The both lungs appears to be normally inflated. The right peritracheal stripes appears to be slightly prominent with the slightly tilt of the trachea towards the right main bronchus towards the right side. And I'm not able to very clearly appreciate the carina. Yes, the carina bifurcation is normal, and only the trachea is slightly.
So I interrupt you. See anything of significance, right, on the AP view? How about this one? This
Okay,
is the same patient.
Yes, sir. Sir, so there is a dense vertebral body is noted in the mid-thoracic spine, and the intervertebral disc appears to be normal at all levels. So this is a solitary ivory vertebra. Also, the diaphragmatic controls appears to be normal. There is no pleural effusion. The heart shadow is within normal limits. There is slight unfolding of the aorta, and however, the hilar structures appear to be normal. So my differentials for this solitary ivory vertebra includes hemangioma, and as the intervertebral disc appears to be normal, there is no reduced vertebral height and no paraspinal soft tissue component. So I'm thinking of a hemangioma as my primary differential. There are few osteophytes also, which are...
All right, okay. So your primary differential in this case is hemangioma. So let's go back to the AP view. Problem is I cannot see my screen as a full. Come on. But
sir, at few levels. Yes, sir.
Okay.
Sir, there is an impression syndesmophyte at one level.
No problem. You see, in exam, always remember, once you make a differential and a diagnosis, the next thing to do would be to wait for the examiner, and or you can offer, you never stop, after you make a diagnosis, don't add further addition to the findings, because then it might take you from your diagnosis. If there are some findings which point to a different diagnosis, then you can mention, I would like to add some other additional findings which I see, which can change my differential diagnosis or diagnosis, and then the examiner can. So do you have anything else which changes your diagnosis from hemangioma to something else?
Sir, there are only fused osteophytes at the level above the this dense vertebra, okay. And but the pedicles The pedicles are intact. The posterior spinous processes are normal. So there is no lysis or additional
I'll
sclerotic.
take the case. I'll take the case from here. So, staying on the lateral view, this is a vertebra. So, is hemangioma always this tense on the plain X-ray, or is it that you see it? If you see another one, do you see something here?
Yes, sir.
Right. So now you have two areas of dense vertebral bodies. You have a 75-year-old woman, true? And do you see a difference in the soft tissues here versus the soft tissues here? What is this triangular shadow? And why is this triangular shadow not here? Why is this?
It can be yes, sir. This
Vertical.
patient might have got a mastectomy, and it can be sclerotic mets.
Yes. So now we are somewhere in the right place to discuss. So this patient has a left mastectomy, has sclerotic lesions in the vertebra. So the first diagnosis, if you have more than one, it's less likely. Usually, you always consider in a 70-year-old patient, you see sclerosis. Even if you think this is a hemangioma, you must mention that a sclerotic lesion or a sclerotic vertebra points towards metastasis. In a female patient, this will be a case most likely of breast carcinoma, and then you look at the breast shadows. If this was a male patient, what would be your first differential?
Sir, sclerotic mets are usually from prostatic CA in the male patient.
So prostatic CA in case. What is the third? What is the third? Relatively less important, but the third one would be lymphoma. All right. So this is the sagittal view of the same patient. You see sclerotic lesions. This is another case. This is just a companion case, and you see multiple sclerotic vertebral bodies. Not necessarily every case is either breast or prostatic carcinoma. This was a case of carcinoid.
Yes, sir.
Now this one is another one. You see some diffuse abnormal radiographies within the bones. Some of them have a fluffy pattern, and there is a left-sided hip replacement, multiple sclerotic lesions. This is a case in a male of a prostatic.
This is a abdominal and pelvis radiograph of a skeletally immature patient, showing there is a large soft tissue haze is seen in the mid-lower abdomen. The stomach is appears to be normally dilated, and no kidneys, no kidney shadow is seen on this current image, and few linear lucencies are seen in the right mid and lower abdomen.
All right, so I'll take it from here. First of all, for all the participants, residents, if you see something on any kind of image that is provided to you by the examiner, the first thing, if you see it's very abnormal, clench it and take some time to explain it. So for example, in this particular case, you mentioned that there is a soft tissue opacity, right?
Yes. Yes, sir.
In the middle. So don't leave it and go straight to the stomach.
Okay.
And some time, because that might be sometimes the only abnormality, and the examiner might be interested only in that. So take some time. Right. In this particular case, you said this is an infant or this is an immature patient. You see an opacity. Why to ask yourself, why is this a soft tissue opacity? This is a soft tissue opacity because the anatomy looks disturbed. Why is so? You see, this is a lucent line, which is the shadow of the psoas muscle, right? Okay, this lucency is this fat which is seen adjacent to the psoas. You don't see it on this side. All right, so you mentioned because there's loss of this fat lucency, I suspect that this might be a retroperitoneal lesion. Now you see this, the air in the abdomen could be either neoperitoneum or within the bowel. If this is not abnormal air, that means it is in the bowel, but the bowel is pushed. So once it is, you see that this is pushed, you mentioned that the other reason I think this is a mass is because the bowel looks to be displaced from its normal position. It's peripherally placed rather than central. True?
Okay.
And you mentioned that this soft tissue, if I think this is a soft tissue mass, you mentioned the bones adjacent to it. You mentioned there is no erosion, there is no destruction in the bones. So now, until now, you see we are still sticking to the main single finding that you have explained. We still have not finished. Then you can mention just very shortly what else other things look like, the bones, the rest of the bones and the soft tissues, and then you come up with a differential diagnosis. So this is a lesion which you think, what would you think this could be in a child or an infant?
Sir, the skeletal immature patient, so it could be of kidney origin or adrenal origin, neuroblastoma or Wilms tumor could be two differential.
Okay, what else do you want to do for this patient?
Sir, CT scan.
Right, now I wanted you to say that.
Yes, I want.
In our setup, we don't want to do CT scans straight up. You can always
sir,
do an
ultrasound correlation.
So if you ask me which one is better, yes, for sure CT is better. But if you have an ultrasound, maybe this thing is not what you really think. Let's do an ultrasound. You see an ultrasound, you have a distended urinary bladder because we saw that there is urinary retention. You see that both the kidneys are hydronephrotic. And then there is a soft tissue, there's a mixed echogenicity lesion posterior to the bladder, right? Now this is posterior to the bladder. Now, does it change your differential?
Posterior to bladder, yes, sir. It's immature patients, so my differentials includes rhabdomyosarcoma.
Very nice. Okay.
And sir.
So let's say it is not rhabdomyosarcoma. What is the closest differential of rhabdomyosarcoma? If you
sir, lymphoma.
In retroperitoneum, lymphoma will be a bit less likely, you see. But if I'd ask you, do you think sacrococcygeal teratoma in a child?
Yes.
Right. So always think about the location and then give your differentials.
Okay.
Just like you said kidney and you straight away mentioned Wilms and neuroblastoma. When you say retroperitoneum, don't mention lymphoma straight away. You mentioned sacrococcygeal, you mentioned, so you can also have neuroblastoma in this. So this is an MR of the same patient. And you can see that we have a low T1 signal lesion posterior to the bladder, ISO to high T2 signal lesion. And this is anterior to the sacrum. You can see that it is insinuating through the sacral foramina into the greater sciatic notch. But you see the adjacent spine is normal. You don't see intraspinal segments. And that is something very important to mention. So although the location is very typical of sacrococcygeal teratoma, but the coxact is normal, and that is where the sacrococcygeal teratoma arises from usually. And then the external component is bigger than the internal component. Because this lesion is going through the spine and is insinuating, this is a neuroblastoma rather than a sacrococcygeal teratoma because of these additional findings. But nobody expects you to give a diagnosis straight away in exam. It's very important to come up with the right type of differential diagnosis so that you can further do do the investigations. So so this was a case of a rather rare, relatively rare case, but as opposed to the neuroblastoma that you usually see in adrenal origins, this is a pelvic neuroblastoma. Usually you see it like this, which insinuates between the structures. It has usually coarse calcifications, and near the midline it crosses midline. Or if you see a child, with proptosis and with periosteal reaction or a soft tissue mass in the orbit, one of the most important things to consider would be a metastatic case of a neuroblastoma. Just like in you see calvareal speculated periostitis, hair on end appearance, soft tissue mass. This child had a bulging eye. Sometimes in a child you would see a raccoon eye, which might look like child abuse, but on the background in the back you would see it's a case of a metastatic neuroblastoma. So serous type of breast carcinoma in a woman can also metastasize to orbit, remember. So that will be a case of rather than a bulging eye, an eye which looks like a shrunken one.
Okay.
All right, this is another case of a neuroblastoma. You see now, this is a different presentation. You have a right paracardiac lesion. You have a right-sided renal origin, partly calcified adrenal lesion, but you see something, there is flattening of the vertebral body. So not every flattened vertebral body in a child is a case of, so what do you think is this one, the other one, adjacent to it?
Eosinophilic granuloma.
So you have a vertebral plana, but you don't see any soft tissue. So a vertebral plana without a soft tissue in a child would be a case of eosinophilic granuloma, but if it is associated with such kind of soft tissue mass with calcification, it's a case of neuroblastoma. And as I said, if you have a pelvic mass, you can have a pelvic rhabdomyosarcoma, you can have a metrocolpos, this is fluid nature, or if it is in the renal origin, it's a Wilms tumor.
Sir, I'm presented with X-ray chest frontal projection of a skeletally immature patient. On the given X-ray, there appears to be mediastinal and tracheal shift towards the left side, and there appears to be radio-opaque haziness projected over the lateral part of the right hemithorax with the reduced lung volume on the right side. And along with mediastinal shift, the blunting of the CP angle is also noted. However, on the left side, the chest and the CP angles appears to be unremarkable. So based on this, with the history of fever, I'm considering it to be a case of some infective etiology, acute onset. Another finding which I forgot to mention is that there appears to be bulky hyla on the right side, which might be suggestive of some nodes in the hyla. So this, my provisional diagnosis in this case would be pleural effusion with of infective etiology, and the other differential in this case could be this effusion could be due to it could be blunt effusion, or it could be if there is if there would be no history of fever, hemothorax would be considered.
So what else would you like to do, or would you leave
so
this
immediately
patient
I would immediately do test tube intubation because of mediastinal shift. Then
but the
I would go
has mild dyspnea, and the patient. So you would like to intubate this patient?
Yes, sir. There's mediastinal shift, so intubation would be
all
done.
Right.
Then I would further evaluate the patient on CT with contrast.
Okay. the patient has dyspnea, but the patient is not desaturating. Okay, dyspnea can be, there's a big difference between dyspnea and desaturation. If the patient is desaturating, you can consider these things. But if you intubate a patient who comes up in somebody's lap or with walking, but mildly dyspneic, and you take him to intubation. Okay, we leave it here. So the purpose of asking this question is, would you like to do any other radiological investigations?
Yes, sir. I would go for lateral X-ray chest,
and how
also.
how can the lateral chest X-ray help you?
So there might be any chest lesion, which because of the diffuse opacity, I might be missing it on the frontal. So I would like to go for lateral, and then I would go for CT examination.
All right. So CT, we will only decide about CT scan if we have a logical reason to do it. Now let's start and let's pick up at the various abnormalities that you see on this chest radiograph. What do you see here? It's number one, a right-sided pleural effusion, correct?
Right side.
There's shifting of the mediastinum to the opposite side. So now a pleural effusion usually would not, this pleural effusion, the amount of it will not cause this much mediastinal shift. You must have seen cases of completely opaque hemithorax, but the mediastinum is not shifted in that pleural effusion. Have you ever seen this much pleural effusion causing this much mediastinal shift? No, they don't fit together. There's something wrong. Okay. Okay. Now look at this this rib. This is the first rib. True.
Right.
Okay. What about this one?
So they appears to be thinned out.
Thinned out and expanded.
Right.
That's something wrong. Now, you said that there is a hilar prominence because there is moderate to massive pleural effusion. This can be a collapsed lung, complete collapsed lung, which looks like hilar prominence. So, all right. This is a CT scan of the same child.
Right. Right.
You see it?
Yes, sir. I can appreciate it. These are corneal axial CT images and the bone window. There appears to be an aggressive-looking lesion occupying the right upper and mid side of the chest, which appears to be extra. So it appears to be extra pulmonary to me, with effusion and erosion, destruction of the underlying ribs, and extension into the intercostal muscles is also appreciated in this case with effusion. So I'm considering it to be an extrapulmonary lesion with rib destruction. My provisional diagnosis would be a primary like sarcoma.
Okay, what else?
Even sarcoma.
Okay, very good.
Sorry, sir.
So, that's good. So I'll take it from there. So because we are short of time, we have to do a lot of other things. So as I said, always look at findings and then correlate. Massive pleural effusion sometimes will not cause this much displacement. There's something else going on. Always look at the ribs. In a child with a pacification of the thorax, yes, effusion is the first one, but always look at the ribs. If you see a mass with a rib destruction, always think of extraskeletal or Askin's tumor or Ewing's sarcoma. This is another case. You see there's permeation, there is destruction, there's a heterogeneous looking mass which is occupying the right hemithorax, destruction of the right rib. So this is the case of Askin's tumor. Now, not every case of mass looking appearance is a case of Askin's tumor in children. There are so many other things to consider. The first case you see here looks exactly the same with calcification. It's a paraspinal mass, similar appearance. The rib appears to be affected. Difficult to see is the case of a neuroblastoma. The other one, which can sometimes look exactly like an Ewing, would be a pleuropulmonary blastoma. So pleuropulmonary blastoma, usually in adolescents, boys, the median age is around 40 months or so. So this can exactly look like Askins. Another one to consider in the same location would be a germ cell tumor. So, but for that, you would see sometimes calcification, mixed attenuation, fat with soft tissues. There's a long list. You can have a rhabdomyosarcoma, you can have chest wall hematomas, you can have inflammatory pseudotumors. First and foremost important thing to consider would be to pick the mass and then leave it the rest to CT scan and histopathology. That's it. So on that particular case, what is important is to pick up the mass, discuss with, mention that I'll discuss this case with the respiratory physician or the pediatrician, and we'll take up this case further, take a pleural tap if required to see if there are any malignant cells there. And if you have picked up the rib lesions, there's no point in doing any ultrasound or something. You go straight away to the CT scan to plan the further management. Right?
Thank you, sir.
And I forgot this one to mention that sometimes rhabdomyosarcoma in a child, which usually might arise from the esophagus